Yeah, well, thank you all for being here. Hopefully you're comfortable in your homes, and sometimes it's a nice way to attend a meeting. If you want, make sure to take a second and get a glass of wine or a beer, feel free. But no, I think it's really important that we kind of try to keep our sense of community during this time. So I really appreciate Winston setting this up for us, because sometimes it's easy to feel like you're on an island and not be in touch with everybody. And we're trying to do everything we can to keep our own education going for ourselves and our residents and everybody else. And so he had this idea, and I jumped at it and was really excited. So thank you all for tuning in. One person told me that not to get mad if they fall asleep. I assure you I won't know if anybody falls asleep, so totally fine. But feel free to chat in any questions that come up, and Dr. Glossy may interrupt me.
On the chat thing below, there's a little screen. You can just put a chat question in. You can either give it to the entire crowd or just to me, and I can help moderate that and get Dr. Cooper all the questions you might have. Okay, so yeah. I'll stop talking now.
I think in a talk like this, I think it's easier if you ask questions as we go rather than save them all till the end. So feel free to interrupt me. If you can't hear me, let me know, and I'll try to do better. But stop along the way for questions. And this is just sort of an overview of acute Achilles tendon ruptures. We're talking about mid-substance ruptures. We're not talking about the chronic degenerative ruptures or the missed ruptures or even the insertional ruptures that we sometimes see, but just straight normal acute Achilles tendon ruptures. So, there's some pluses to being at home a lot. This is my 11-year-old son. He is almost that skinny, not that tall as he looks in his picture, but this was my dinner tonight. He wanted to make bacon-wrapped cheeseburgers, so he found a recipe, and so they're learning different things, and I'll show you some of the examples as we go. But, try to keep them entertained and educated, and they were delicious. So this was another, if those of you haven't seen me in a while, my hair looks different, and there's no barbershops open, so good excuse to cut all my hair off, and I let my daughters do it the other day, so they enjoyed that, and it's very comfortable, so happy. So I don't have any disclosures relevant to this topic. So just a general about acute Achilles tendon rupture, they happen about 9.9 to 55 out of 100,000 people per year. So pretty broad range, probably somewhere in the middle, around 20 out of 100,000. But it has been noted to be increasing over the years. Most commonly associated with sports, males are much more common than females, accounting for up to 90% in some studies. And most commonly between the age of 31 and 50, although we're seeing more in people over the age of 50, even 60s and 70s as we become more active. And there's sort of a bimodal peak. Some of those more elderly or older patients have either a higher rupture near the musculotendinous junction, or they've got more of a degenerative rupture that just becomes an acute rupture. But still, the general trend is 31 to 50. We still see some in the teenage population. I took care of a high-level high school basketball player a few weeks ago, and so it does happen. So she's very atypical, being an 18-year-old female. We don't see that a lot. Interestingly, the rate of surgical intervention, at least in a big study out of Sweden, has been decreasing despite the increase in ruptures. If you look in the U.S., and this is sort of dated now from 2007, 2011, it was still, increasing the rate of surgical to non-surgical treatment. It was more for males than females. So how do we get here? What are the controversies? And so the big controversy, at least on the initial setting, is do you operate or do you treat these non-operatively? And, when I was in training, 100% of people got surgery, and that was, only 12, 15 years ago. And this was based on some studies from the 90s that showed really high re-rupture rates in patients that were treated non-operatively, and they found a better return to sports and functional outcome with surgery. Some of the studies showed up to 39% in one re-rupture rate with non-operative treatment. And so you could see how that would push one to just say, if you rupture your Achilles, you need to have it fixed with surgery. A big meta-analysis in 2002 kind of looked at all of these studies and pooled a total of 448 patients, and they found about 1/3 the risk of re-rupture in patients who were treated non-operatively, or excuse me, 1/3 the risk of re-rupture in patients who were treated operatively, and so that favored operative treatment, and that's a big study, and that was based on pretty much what they felt were all the high-level studies at that time. And Dr. Bandari actually came and spoke here about a year ago, is sort of almost the world guru for meta-analysis in orthopedics. He's really pushed that field beyond what anyone else has done. The one thing to take away from this, though, if you go back and look at all these studies, is that all the non-operative studies used casts for at least 6 weeks. And if you look at the dates of those really high-level studies they found, they were all prior to 2007, some even far back as 1981. But they did all favor non-operative treatment as far as complications go. Or excuse me, they all favored operative treatment as far as complications, primarily re-rupture. So this is another thing we've done over this time. My daughter has finally learned to ride a bike. So fortunately in Virginia, the weather's been spectacular. So since I haven't been able to operate, I've had a little bit extra time to teach her things like that. So what are the questions about Achilles tendon ruptures? So operative or non-operative, for me as an orthopedic surgeon, this is the number one biggest question. But if surgery, if we are going to operate, do we do it open or do we do a minimally invasive surgery? And then what's the best post-operative protocol for these patients? And I will tell you right now, don't stay on here if you're just hoping I'm going to answer that, because I don't necessarily have the answer to that. Maybe one of you can share it with me. In 2010, which doesn't sound that long ago, our society published a treatment guide or a position paper on Achilles tendon rupture. This was in the Journal of the American Academy of Orthopedic Surgeons. And initially when it was sent out for review, the only recommendation was, the only thing they had to recommend of all the options and all the controversies was that percutaneous repair was better than open repair. And this was 10 years ago, and no one was doing percutaneous repairs, hardly. And there was a huge outcry. And before it was ever published, everyone wrote letters and said, you can't publish this. This will ruin us. If anybody has a wound problem or in trouble, don't publish this. And so they removed it. What they did report was that, and this was like one of the only things that they felt strongly about, was that a history and physical exam should be performed. Well, that's sort of a given for everything. But they even said that was in the absence of any reliable evidence to prove it. They were unable to recommend for or against any advanced imaging like ultrasound or MRI. There's a pretty good study that's recently come out several years ago that showed that MRI really has no benefit in treating acute Achilles tendon ruptures, and that, in fact, the only thing it changed in the outcome was that it delayed definitive treatment. Non-surgical treatment's an option, but they said that was a weak grade. They were unable to recommend for or against functional bracing in the non-operative treatment. And then, again, surgical treatment's an option, but a weak grade. They said you should be cautious with patients with a lot of risk factors. And so a lot of just sort of common sense answers with no real definitive recommendations. They did say that both types of surgical options were viable, and that, there were slightly higher wound complications in the open sort of, where you see the large incision, there were more wound complications in those, but they had other nerve injuries in the percutaneous treatments. And so they couldn't recommend for or against any kind of augmentation of the repair. And so basically that's the question there is, do you add any extra tissue to the repair? Do you inject them with PRP at the same time or anything like that? They didn't know. And they didn't know what to do for deep vein thrombosis. And so a lot of these things haven't changed a whole lot. They did suggest early weight bearing for operatively treated patients, and I think we still feel that way. So then later that same year, a huge, or what I consider a large, randomized study came out over the management of acute Achilles tendon ruptures, and they had 144 patients, and they randomized them either to surgical treatment or non-surgical treatment with functional rehab, basically letting them weight bear early, putting them in a removable device to start some range of motion and things like that. And then they followed them for 2 years. And what they found was that the re-rupture rate wasn't that great. It was 3 to 4% in both, no significant difference at all, and only a slight improvement in strength in the operatively treated group. And I think it was sort of a landmark paper because it really, at least in America, changed the way people thought about these. Before that, there was not a lot of attention given to non-operative treatment. And after that, it really caught on. And so a lot of these have been treated non-operatively in the last 10 years. They did find slight increase in complications in the operative group, but really no difference in the scores, the patient outcome scores, the Lipolati score, which is sort of a commonly used Achilles score, less commonly used now than 10 years ago. And overall absolute strength was the same. These strength differences they saw were only at very specific basically RPMs, 240 degrees per second. Another study out of New Zealand looked at 363 patients. It was totally non-randomized review, but they also found that they did fairly well non-operatively, but they did note a slightly higher rate of re-rupture in the non-operative group of 8.6%. And they found that was highest in males, less than 40. And what they suggested was that it was due to a combination of their demand, their strength of the gastroc soleus complex and its ability to re-rupture it, and also questions of compliance. We know that 30-year-old males are often not the most compliant group of people. And so they recommended, the only thing they really recommended was non-operative treatment for females over 40. Another large study out of Britain in 2011 looked at almost 1,000 patients and treated with non-operative management. One thing they did was they looked in the clinic with ultrasound to see if the tendon ends opposed one another. So they plantar flexed the foot with ultrasound to see if the tendon ends would come together. And if they did, they treated them all non-operatively. This is sort of their overall protocol, but they got them in a pneumatic walker with heel lifts by 4 weeks on all of them. And they had them start a rehab about 8 weeks later. So again, not casting, not immobilization. We know that's bad for tendon healing. You know, we take a lot of that from our hand colleagues who are the sort of the masters at early tendon motion with their flexor tendon repairs and things like that. And they've shown that they get a stronger repair with early motion, less adhesions. But ultimately, you know, they found that about 0.6% of them had tendon lengthening, which is not a huge number, and that did lead to some weakness. Low rate of deep vein thrombosis, and again, a low rate of re-rupture. And so again, we're just more evidence that you can treat these non-operatively. You know, they reported that all of their patients returned to pre-injury sport level. They didn't really designate what that level was, so this was not necessarily a group of high-level athletes. It was sort of a very heterogeneous group, and that they would return to work in about 5 months. You know, some patients, that's a long time. So in summary, you know, I think where we are now, there's still slightly higher risk of re-rupture and non-surgical management. It's probably somewhere around 5%. I personally think the bigger issue is with increased elongation of the Achilles tendon with non-surgical treatment. And what that does is it takes away the power of the gastroc soleus complex, and particularly in a young laborer or young athlete, you know, they're gonna notice that. You know, some other people might not notice it. Maybe I wouldn't notice it. I'm certainly not in that category. So I think we still lean towards, at least in America, surgical treatment for young active patients. That's not the summary of the talk. That's just a summary of that section. Here's another thing that we've accomplished during our time at home. As one of my daughters accomplished over 40,000 steps a week ago one day. So that's I think a family record for sure. I've never had that many steps. So we're trying different things. So we'll move on to sort of the different surgical options, and the two main groups are either open, which is sort of the traditional thing where you make about a 4 to 6 inch incision right over the Achilles tendon, open up the peritoneum, which is the sheath around the tendon, and repair the end side to side with sutures. In the last 15 years, there has been a lot of interest in more minimally invasive or percutaneous repair techniques. I think that initially the feeling was you could cut down on wound complications, because if there's anything devastating in Achilles that's much more devastating than a re-rupture or elongation is a wound infection. And that can really change someone's life and lead to even having to remove the tendon. And so I think that was really the driving force for this. And so they came out with some of these devices that a couple companies made where you could slide this thing in and pass these sutures. And there was concern that you're putting them right through the sural nerve, which runs right on the outside of right on the lateral side of the Achilles tendon, or that you weren't really capturing the tendon, or that you were going to capture the skin and cause some puckering. But it led to some advances, and people really started looking at that and seeing, are there advantages? And what we found is that, there are potentially lower wound complications, lower scar tissue in general, and maybe lower adhesion issues. When I talk about adhesion, when you open the whole thing up and you look at those tendon ends and you sew them together, and then you try to close this peritoneum around it, and then you close the skin over there, all three of those levels sort of adheres together. And so you'll see some patients where they dorsiflex and plantar flex, and their skin, their big keloid scar or hypertrophic scar is moving with the tendon, and that's not great. The other feeling was that it would allow for quicker mobilization because you had a much smaller incision and lower risk of wound healing problems. Potential downsides, I think there's a learning curve. There certainly was reported to be a risk of sural nerve injury. That's pretty much been, we've worked out ways to avoid that. And some of the newer techniques, I don't think it's an issue. And again, that puckering of the skin, again, I'll show you my technique, and I think we've avoided those things. And then the question was, is it more difficult to oppose the ends? And I think in a case where it's not truly an acute rupture, say, 6 days or 10 days or less than 2 weeks, if you get to that 3-week range, you start to worry about, pretty consolidated hematoma in there in between those ends, and you're not going to really be able to regain your tension and pull the proximal end that's retracted back down to the distal stump, because that's really all you need to do. The distal stump, where it attaches to the calcaneus, is not under any real tension. It's not elastic, but the proximal stump attached to the gastroc and the soleus really retracts. And so you really need to pull that proximal stump down to regain your appropriate tension. A rabbit model did look at open versus percutaneous repair, and they did find improved collagen fibrils, higher number of collagen fibrils, as well as a more normal histology at 8 weeks after a percutaneous repair. And I think this is where we're really seeing some of the big differences, is that, you know, by not violating all of the hematoma and not violating the peritoneum completely, we may see actually better tendon healing. They didn't, at that point, at the 8-week point, find any difference in the strength to rupture. Probably one of the biggest clinical papers looking at minimally invasive techniques was by Keller et al. In the American Journal of Sports Medicine 2014. And they treated 100 consecutive patients with a minimally invasive technique. They had them back to work in about 8 weeks and returning to sports in under 5 months, which is pretty remarkable. You know, I generally don't encourage my patients to do that, but the fact that they did that is a good sign. They had a very low re-rupture rate, 2%, which I think, you know, is probably in line with what most surgical techniques will show. And importantly, at that time, they didn't have any sural nerve injuries. So the sural nerve, again, runs, you know, kind of posteriorly down behind the gastroc and then curves to the lateral side of the foot. And it's not so much the numbness that bothers people, it's a painful neuroma, and that can cause some significant debilitation. They also found at the end of the study equal side-to-side strength at 42 months. Another meta-analysis looked at this, and there was just recently one published, you know, in the last year that I apologize for not adding to this, but they did a meta-analysis and found that they had actually better ankle function, higher patient satisfaction, and a lower complication rate with the minimally invasive. And so a lot of the data and a lot of the evidence points towards a slight favor of minimally invasive procedures. Conclusion, both are acceptable. If you use them appropriately, I think they're fine. You know, and like I said, for the subacute cases, I think you have to open them up. If you do open them up and use good soft tissue technique and try to close that peritoneum over the tendon, I really think you can decrease your wound complication risk. I think you have to look at the patient factors. If they have a lot of risk factors for wound healing, such as if they smoke or if they have diabetes, I would really lean towards a minimally invasive procedure. I do think it decreases the complications overall, and I feel more comfortable about getting them moving a little bit sooner. The other thing I've noted anecdotally that some of the literature support is that they have less concerns about their scar, whether it's cosmesis or just sort of a thick scar that kind of they feel like is attached to the tendon. I don't see that nearly as much. So this is my technique. I make a small longitudinal incision over the sort of proximal to where I think the gap is, because you want to make that small so you can pull the tendon out, and then I pass my sutures into it. So this is the same type of suture I would use if I was doing an open repair. I just don't open this end of the tendon and put sutures in that. And so I take these 2 sutures and I make 2 tiny poke holes down here in the back of the calcaneus, and I pull this, put it back in the skin obviously, and under the peritoneum, pull those sutures down and attach it directly to the calcaneus with suture anchors. And so all we're doing is restoring the tension between the gastroc up above and the soleus to the calcaneus, because that's really all that matters. The Achilles tendon itself really heals well. On the cases I've gone in where someone's been 6 weeks from a rupture and it was either missed or for whatever reason they didn't have any treatment, the tendon really wants to heal. It's already started to heal, and you have to excise a fair amount of tissue. And so all you need to do is get the tension between the gastroc and the soleus and the back of the calcaneus intact, and the body will do the rest. And so that's what we do. And I think this is becoming more and more common. Again, I don't make this type of incision because I feel that if for some reason there is an issue and we need to extend it, I want to be up and down so I can go, you know, longer if need be. But usually it's about a 2 to 3 centimeter incision, a little bit proximal to where I can feel the gap. The other thing that I would report is that I try to make it as tight as possible. You know, sometimes I leave the operating room and I worry that somebody's never going to get their motion back. I think most of them seem to. The bigger issue is if you leave it too long and they're weak, especially in an athlete. And, you know, this has been reported anecdotally. And then finally, recently in the last year, there was a study that went out and they found that the only 2 factors that had any impact on the patient's strength, those treated surgically, and their strength and their ability to do a single leg heel rise and how high up off the ground they could get their heel, was, number one, their age. So if they were younger, they were better at that, and that makes sense. And number two was how tight the repair was reported to be at the time of surgery. And so the recommendation is generally to make it as tight as possible. And I think with this technique, you're not so much limited as you are with a major open technique where you're putting sutures at both ends, because when you really try to pull that tight, it's like two mop ends. And so you're pulling it tighter and they're bunching up more and more, and you get this giant scar ball. And I think with this technique, you can kind of avoid that, and that's nice. Have we had any questions at all? I know Winston sent me a text on my phone. I couldn't see what that was, but anyway.
I don't have any questions yet.
Or somebody sent me a text stuff.
Please use the chat if you guys want to ask questions. I'm right here.
Yeah, well, I'll just keep talking, and if you have questions at the end, great. If you're asleep, that's fine too. If you're putting your kids to bed, I understand.
Worry about overuse injury in your daughter at 40,000 steps. Well, that'd be our next topic.
No, because the 3 days prior and the 3 days after, she probably didn't do anything, so she rested.
You got to build up tolerance.
Okay. Yeah. So this is actually my daughter, and so this is a couple of weeks ago. She unfortunately broke her arm the first day the school was canceled. So they canceled school on a Thursday, and on Saturday she broke her arm. And so the good orthopedic surgeon I am, I took her mountain biking that day. She went over the handlebars, broke her arm. But also the good orthopedic surgeon I am, I let her just ride a horse with a cast on. So I'm asking for trouble. But, during this time, I just can't keep her in the house because she usually doesn't want to do anything, and she gets really mean if she doesn't get to be around horses. They're her therapy horses, that's what I say. So, yeah, we've had some different adventures.
3 questions real quick.
So postoperative
Hey,
what's that?
Truitt. So a couple questions. You mind if I ask right now? Do you
No, please do.
A gastroc soleus turn down for quicker return to activity?
No, not. So what I think he's asking is, so a gastroc soleus turn down is where you can basically take a strip of the so the gastroc becomes fascia and tendon much higher than the soleus, and then they blend to become the Achilles tendon. And so you can take a strip of that tissue and flip it down or just translate it all the way. And, in the acute setting, I don't think there's a role for that. I think in the chronic setting where you're excising some degenerative tissue, or you have a gap after, if it's a delayed repair, you can flip that down to fill in that gap. But I don't think there's any role for that. And if you look at the studies on augmenting acute repairs with different collagen carriers or things like that, they really haven't shown any benefit, and I think they do have a slightly higher wound complication for those augmentations. Probably not a wound complication issue for taking their own gastroc and flipping it down, but there's no role for that, I don't think, in the acute repair of a normal tendon. One question that gets asked a lot is, are these Achilles tendon ruptures? Is it all because there's a degenerative tendon anyway? And I don't think there is. I think the MRIs all suggest that, but it's really just all this fluid in the acute rupture. But most of these young athletes, the tissue is actually pretty healthy, and it's just a fluke thing. Some of the older people will have degenerative ruptures, and you get in there and the tissue's poor, and you do have to excise it. And if you have a defect, that would be a time to do either, like he said, a gastroc turn down. You can do an allograft tendon reconstruction with a cadaver, or you can also augment that with a flexor hallucis longus tendon transfer, which we do a lot for the degenerative, especially insertional Achilles tendinopathy, but I don't think there's really a role for it in the acute setting.
Another question. What is the reasonable time period to expect propulsive activities in a 35 to 40-year-old? Someone like me, Duncan. Yeah,
so I guess propulsive activities, walking sort of a propulsive activity, but if you mean running, I generally tell my patients if their livelihood is not dependent on sports, if they're not a college or a high school player who needs a scholarship, or a scholarship athlete, or somebody who's going to play professionally, if it was me, and you're younger than I am, but if it was me, I would tell them give it 6 months before they try running. There's people that can do it much, sooner than that. But to jog, I tell them, look, your livelihood depends on being able to go to work. Your livelihood depends on getting through this and not having any complications. And your wife is going to kill you and me if you re-rupture this thing. And so I tell them give it 6 months before they try to do much running. And I tell them if they can give it 9 months before they try to play soccer or basketball, they're better off. And if you look at even the high level athletes, they have problems in a lot of cases when they come back too soon. you see reports of NFL players coming back in 4 months and things like that. And maybe it's possible. I don't know if that makes it a good idea. If you look like somebody like Kobe Bryant, he tore his Achilles towards the end of his career, and that happens a lot. Dan Marino tore his Achilles towards the end of his career, came back, but was never quite the same. But was he not the same because he was 37 or 38 years old and missed, 6 or 9 months? But, when Kobe Bryant came back, he ended up with a stress fracture in his tibial plateau because there's so many other factors that go into coming back versus just the strength of the tendon itself. And I think, the biggest issue is probably getting that, precise gastrocsoleus complex function along with the peroneals and the posterior tibialis and things like that. That's what really takes a long time. And you got to have that strength and that protective strength before you really come back to sports.
So you're saying I shouldn't pick up Kevin Durant on my fantasy team?
Well, he's going to be a year. He'll be close to. He'll be over a year since he ruptured by the time he comes back. So yeah, he should be okay.
A couple more questions. What is the expectation for return of the previous amount of ankle dorsiflexion to that of the opposite side? Do you expect it to be symmetrical to the opposite side? Or?
Yeah, that's the goal. I think the one thing you really don't want to see is them to have more dorsiflexion than the other side, because that means that whatever treatment they had failed, whether it's surgical or non-surgical. If they have more dorsiflexion than the other side, then you failed them, because they will never get their strength back. It's like a pulley with tons of slack, and you can pull all you want, and it's not going to do anything. I think if they're a couple of degrees shy, if they're opposite leg dorsiflexion, that's probably okay. I think most people can get it back. When we're in the operating room and we're putting these things as tight as we can, we're fighting 2 weeks of a serious gastroc contraction. So we put those sutures in, that process stuff, and we pull on it for 5 minutes, in a lot of cases, sometimes longer, just pull. Hopefully it's the resident, not me, but somebody's got to sit there and just pull on it and try to get it back down and stretch it out before you put those sutures in distally. But I think the goal is certainly to get even, but I think if they're a couple degrees short of the other side, but they have good strength, that's probably worthwhile.
Does the decision of operative or non-operative management depend on the rupture gap? For instance, do smaller gaps do better with non-operative management, or is there any evidence?
I think it does. I don't think it does. I think it depends. For me, it depends on a couple of factors. Number one, what's the patient? Well, I offer them all both for the most part, but I will guide them one way or the other. But for me, what's the patient? If they have a bunch of medical issues, if they're not very active, I generally steer them towards non-surgical treatment. I think in patients, over 60, I generally steer them towards non-surgical treatment. Although if they're healthy and they're very active, then I'll give them the option. I don't think that the actual gap, I think even with ultrasound, I don't know that you can really, it totally depends on foot position. So if they have a rupture and you dorsiflex them, their gap's going to be like 6 or 7 millimeters. If you plantar flex them, or 6 or 7 centimeters, if you plantar flex them, it should be very little. Then when they're in the MRI machine, you don't really know what position they're truly in. And so for me, that's not a factor because there's always a gap. And the bigger factor is how long has it been? If they have a rupture that's 3 weeks old and they haven't had any initial treatment, because the initial treatment for non-operative management is actually at least 2 weeks in plantar flexion and a splint. And so if they either don't go to the ER or they go to the ER and it gets missed and they've just been walking on it for 3 weeks, I think they have less of a chance of success for non-operative management because there's already formed this sort of hematoma that's starting to consolidate and form some sort of scar tissue or collagen in between those two ends. And you can't, by plantar flexing them for those two weeks, you can't sort of get them to start to stick together a little bit.
All right, last question for this session. Do you use functional objective testing, i.e. a LEAP test to return to sports?
We don't. For me, I generally, it depends on, again, a lot of it depends on what the patient needs. But I think in the high level athlete, they're usually working pretty closely with their athletic trainers and things like that, or their physical therapist. For me, I do, if they want to get back to sports, one of the sort of the simplest criteria is like, can you do a single leg heel rise? If you can't do a single leg heel rise, then you should not be really running on this. You should not be even considering. And so I think that it's different from athletes and depends on what their needs are. But no, we admittedly don't necessarily in our clinic use that. Now, like I said, the people that are going to high level sports are usually in a facility where they're with their athletic trainers and we're working with them, and they may have their own sort of ability to do those tests. But you know, that kind of stuff we don't do in our clinic. Some of the physical therapy clinics may do it, but that's a good question. And, you know, I think that's sort of the next phase of things in management of all kinds of orthopedic problems are developing these really specific criteria. You know, it's the same thing with all the things I treat and all my different patients. They say, you know, when I tell them, okay, you can start walking a little bit on this, they say, well, how many steps is that? And we don't have the data to tell them 2,000 steps okay, but 7,000 is not. Or, you know, can I go get my, you know, you can go get your mail, but don't go to Costco, those kind of things. And I think that's a really important thing. You know, again, you know, I know Dr. Wathany's worked a lot, you know, with our kinesiology group here, and they're doing these LEAP tests to try to define, you know, what are all the criteria that someone with an ACL tear needs to meet to get back to sports. And we're admittedly a bit behind in foot and ankle and that kind of stuff, but I think it's a great question, and it's where we need to go with this, because as I'm going to talk about here, the rehab is every bit as important as the surgery.
Keep rolling, man.
All right. So I'm not going to go into great detail about specific protocols. I think a lot of the audience could educate me pretty dramatically about this, but you know, today it's not quite as controversial as it was, you know, 15 years ago, 20 years ago. Most studies support early weight bearing and rehab, and that's true for both surgical and non-surgical patients. You know, one of the big recent ones Zellers et al. And last year they did a systematic review looking at 150 publications that described early functional rehab, and the big conclusion they found is that, you know, most of them mean early weight bearing, but there's no standardization into what early rehab means. Some of them had early weight bearing with range of motion. Some of them had early weight bearing in a cast. Some of them had, you know, early strengthening, unlimited range of motion. So there's really all these things that say early rehab is good. There's no definition of what early rehab really is that's consistent. And so, you know, a couple of studies in 2014 looked at immediate weight bearing, which to me, immediate weight bearing is 2 weeks. Some of the studies in Europe will look at like immediate weight bearing, like 2 days. Those patients realistically are not putting any real weight on it. And if you look at the groups where they did put weight on it right away, they had more hematomas and more issues. But the important thing is that they're all limiting the dorsiflexion early on. And they found that early weight bearing, controlled motion, and some sort of Achilles brace or boot with a heel lift, or even a weight bearing cast, they did have quicker return to sport and work. They have higher satisfaction, less atrophy, and greater strength. And they did not find any increase in re-ruptures, because that's what you worry about. They're taking their boot off and walk into the shower and they slip, they re-rupture. There was an NFL player 3 years ago who was on one of those knee scooters and fell off and re-ruptured, you know, because those things aren't rated to 350 pounds. Recently, this year actually, randomized controlled trial looked at early weight bearing versus delayed. And what they found was that there were improved outcomes at 6 months with early, but no difference at a year. And I think that's probably accurate. You know, I think patients are going to be happier if you let them walk sooner. That most of the studies for ankle fractures that have early weight bearing find the same thing, that they generally have better range of motion early on. They're happier because they're back to work a little sooner, they're walking, but there's no long-term real difference. You know, one of the big things is you want to limit that dorsiflexion range of motion because you don't want to stretch the tendon. The greatest tendon lengthening after surgery comes between 2 and 6 weeks. And there was a really good study that showed that whether they were in a cast for those 6 weeks or whether they were in a removable brace or boot, they all experienced lengthening between 2 and 6 weeks. And they did this, when they did the surgery, they put these little tantalum markers and then above and below the repair in the Achilles, and they took x-rays at different periods and saw how far apart those markers stretched from the baseline. But it doesn't seem like early weight bearing, early range of motion really affects how much lengthening you get. It's going to happen a little bit anyway, and that's why we put them tight as we can. So for me, and what most of the literature, at least orthopedic literature that I've reviewed, would suggest is that you really want to limit at most to 15 degrees of plantar flexion in the first 2 to 3 weeks. So that's 15 degrees below neutral. After that, you can start bringing them up to about 5 degrees, and then, you know, at about 6 weeks is when you're going to try to get to neutral. And that's true in their weight bearing. Again, whether it's an Achilles brace that's, I don't actually use those. I prefer a standard boot with a heel lift that's graduated and they can peel off a piece at a time to gradually increase that. But you want to get them moving. You want to be able to get them out of the boot and moving and start working on some of that range of motion. And then, I tend to, in a compliant patient who's doing well, let them wean from their boot around 10 weeks or so. Sometimes a little bit longer if I'm worried about it. Sometimes occasionally a little bit early if they're doing really well. But it's usually for me about 10 weeks. That's about how long it takes them to get all those heel lifts out of the boot, get flat for a week or two, and then feel comfortable getting it out. The questions are really, the goal is to really, protect the tendon during its healing, but you want to get some stress on the tendon because tendons just heal better with some stress. You want to limit that gastrocnemius atrophy and the loss of neuromuscular function, and you want to return to normal. It's important for people to get back to work. Now more than ever, and avoid over lengthening because again, what I said, I really feel this. It's better to have them a little too tight than to have somebody come into the office and do this. This is the left foot where they're over lengthened, and if that patient's never going to get strength out of that, they're never going to get their power to jump or push off or run. They can probably walk okay, but they're not going to get much strength out of that. And so, most patients are going to be able to return to sports. I think it's rare before 6 months. I think it should be rare. I think unless you have a lot to gain, you're risking a lot. And one interesting study, though, that came out in the last couple of years showed that they looked at underclassmen college football players with a rupture, and they found that 90% of them were able to return, and they continued to improve. They had more tackles after their rupture than they did before. But again, these are freshmen and sophomores. But compared to their cohorts, a much smaller percentage of them made it to the NFL or even to the NFL Combine than the controls. And so, and you wonder, is that because their performance never got quite to that level? Is it because, there's, when the NFL scouts and team docs are looking at these patients' medical history, they see a red flag. And if it's a patient who has had an Achilles rupture and a patient who's not, well, they're going to take the one who's not. And so it was still an interesting study, but it was really significant how many fewer of them made it to the NFL compared to their controlled cohort group. I think the questions regarding the rehab and things like that, I think a lot of it involves when do we really start strengthening them? Is it better to start even some general strengthening at 3 or 4 weeks, or do you wait till 6 or 8 weeks? And how fast can we go on that? And I haven't really been able to find a definitive answer for that. I tend to err on the side of going a little bit slower just because I'm scared, but there's no science to really support that. Future controversies, the question of do we use platelet-rich plasma with these, or any stem cells or other biologics? None of those have been shown to make really much difference in the healing. Do we augment them with different collagen scaffolds? I think for the most part, nobody's really experimenting with that. Can we use different fibrant glues? I think the big things are going to be based around more of the rehab. I think it's pretty clear that minimally invasive surgeries are the way to go. I think early rehab is good, but what does that really mean, and what's the optimal rehab? And, what can we do to prevent these injuries? And then lastly, what's the criteria to really go back to sport other than, yeah, you look pretty good. You got good strength, you're cutting, you're not hurting. Yeah, go for it. So I really appreciate all you guys coming out and being here. Not many people have chimed in, but if you do have questions, please do. I'm just happy to have everybody out and feel like we're doing still trying to get better, taking care of patients.
A question for you. Do you have any research based on anecdotal evidence of using BFR to help decrease atrophy?
Using what?
BFR, blood flow restriction, like to decrease atrophy as part of therapy?
I don't know anything about. I don't have any knowledge of that, to be honest.
You get that, Truitt?
No.
All right. Hey, Truitt.
Yeah.
Yeah, so that was awesome, man. I do appreciate that. So, yeah, blood flow restriction, a lot of our athletic trainers are using to help with just early healing for, ACL injuries and things like that. So.
Yeah, I don't know anything about it. I feel like in a lot of these tendon and cartilage issues, we lag behind our sports medicine colleagues, admittedly, and so that's something I should look into. I haven't heard of it being used in Achilles tendon or other tendon healing issues, but maybe it's something to look into.
Well, what they do is they basically put tourniquets around your proximal thighs, and then you can basically change sort of vascular dynamics of the limb so that you can basically exhaust the muscles at a much lower stress. I mean, basically you can maximize the recovery using much less effort and time. So
it's really more for the muscle.
Yeah, our athletic therapists will use it for lower extremity injuries. Is kind of nice.
So it doesn't have anything to do with the tendon healing itself. It's just to fatigue the muscle without stressing with lower loads.
Fatigues the muscle fascia without stressing the repair. Exactly. That's awesome. Well, I don't see any other questions coming through the chat board. Any other questions from the group while we have Dr. Cooper here? All right, my friend, Truitt, that was awesome. I really do appreciate it. So just as far as announcements go, please invite your friends if they want to be a part of this. Therapists, athletic trainers. These talks are these are designed mainly for people who help us or rehab our athletes, and so we're going to try and keep it sort of built in that direction. So if you have any friends out there in your group or any other athletic trainers out there, listen, that will add them to the list. But I think next Thursday night around 7 o'clock, Dr. David Dudek's going to talk about cartilage repair in 2020. And again, if you guys have any topics you guys want to cover, please let me know. I know Dr. Chabra wants to give a talk, so if you have any upper extremity types of questions, you can ask. He can give a talk on that too. So without further ado, I'll let you guys get back to your evenings. All right. So thanks again, Truitt.
Thank you.
Adios.